Making it live now.
We are live. Hello.
Yes, it is started.
Good evening, everyone. I welcome you all to this webinar on the muscle talk. The sarcopenia. I welcome the panelist, Dr. Anand Kishore Paul, and our chairperson, Dr. S.S. Jha.
Hello.
We will start the program with the lighting of the lamp, please. Having invoked the blessings of God, let us start the program. But before we start, let us all pay deep homage and respect to one of the tallest orthopedic surgeon in the world, Dr. Chittaranjan S. Ranawat. We have lost him today, and it is a matter of great sorrow for all of us. Everyone knows Dr. Ranawat's contribution. I have attended his joint replacement workshops and programs in Bangalore, and we are all impressed by the amount of dedication and hard work and the trouble he takes to train many orthopedic surgeons in joint replacement techniques. He is one of our India's pride. We will never get another Dr. Ranawat, and we are extremely sorry that on this day we lost him. Our deep respects, deep homage to him, to this tall personality in Indian orthopedics and global orthopedics. And we pray the Almighty that his soul is blessed abundantly, and God gives his family and all his supporters that kind of support to bear this unimaginable, irreplaceable loss. Let us just observe 1 minute of silence before we proceed with the program. If Dr. Jha wants to tell something about Dr. Ranawat, I request him to please tell a few words.
Right. So this gentleman who started his journey from Indore, reached United States and saw to it that total joint replacement gets its identity throughout the world. I had the chance to attend so many Ranawat joint replacement courses, and he was par excellence. What is most important, I will remember that while he was at the peak of his joint replacement career, he had thought of when to retire. And luckily, I was present in Bombay course when he said, look, my hands are okay. Without taking support of my hands, I can go down the stairs. And he got down the stairs and said, this is the last day of my practice. So I think this is a great tribute. And in one of the orations, he had said that he was a mediocre student in his medical school, but then he got committed to the knee joint replacement and showed that excellence can be had at any stage in life. A great message. Thank you.
Thank you. Dr. Anand Kishore Paul, do you want to pay your respects to Dr. Chittaranjan Ranawat?
So Ranawat was like the god of orthopedicians.
So he was actually the idol of many orthopedic surgeons like me. So it is a very, very sad news that he is no more. And I think he remains alive forever in every orthopedic surgeons.
Right.
So I'm giving a tribute to him, and I'll provide respect to his departed soul. Thank you.
Thank you. Thank you, Dr. Jha. Thank you, Dr. Anand Kishore Paul. We all join to pay respects to this legendary orthopedic surgeon. Now, let us carry on with our the webinar. I'm very proud and happy to announce the association of Format with Geriatric Orthopedic Society of India. They have come forward to be a part of GOSI in a very big way. We are going to have many webinars like these, and they are going to take up our journal work for the next 3 years. And they're also going to be a part of the JOSICON International Conference at Chennai in November. I thank the entire management of Format coming forward to be associated with this organization of ours, which is here to serve the geriatric population. And we want to train orthopedic surgeons to handle geriatric problems, because geriatric problems are different from adult problems, and we need to sensitize our orthopedic surgeons as to how they need to handle the geriatric patients with humanity, care, love, sympathy, affection, not just with scalpel, plates, screws, and the implants to change the joints. So that is our purpose. And today the webinar is a bone muscle crosstalk, and the talk is on osteosarcopenia and its impact on orthopedic conditions and recovery. And osteosarcopenia is a silent thief. Slowly the muscles and the bones are being wasted, and one fine day when we fall and break the hip or the bone, we come to realize that we are suffering from a condition called osteosarcopenia, and that would be too late. So here this webinar brings into focus the importance of knowing about this osteosarcopenia and what is that we need to do. Next slide, please. This is about me. I'm Dr. John Ebenezer, based in Bangalore. I am the founder president of the Geriatric Orthopedic Society of India. Next slide, please. And our keynote presenter today is Professor Dr. Anand Kishore Paul, a very senior orthopedic surgeon, professor and head Department of Orthopedics, JGMCH, West Bengal. Former professor and head Department of Orthopedics, IPGMER, SSKM Hospital, Kolkata. I welcome Dr. Anand Kishore Paul for this webinar, and I wish him all the best. And we are here to learn from him about osteosarcopenia and how we should overcome or face this very serious problem. Next slide, please. And here is our beloved Dr. Shivashankar Jha. He is one of the tall, legendary orthopedic surgeon of the country. He is a pride of Indian orthopedics, and he is like Pitamaha, and he is like our banyan tree under which we all grow. I have been associated with him from many years now, and he is the patron of Geriatric Orthopedic Society of India, and he is the patron of our journal too. And most importantly, I have got a very great personal relationship with him. He is our very good friend, always supportive, always speaks good, always is encourageable, and his knowledge is unimaginable. I keep wondering, from where he gets this kind of knowledge, and he is updated to such an extent that he can put even the youngest orthopedic surgeon to shame. So that is the quality caliber of Dr. Shivashankar Jha. And it is immense pride that he is chairing this session. When he is around, I can relax. He will take care. He will take care. So that is the quality Dr. Jha brings in. He is the director of Harishchandra Orthopedic Institute, Patna. He is the patron-in-chief and founder-president, Indian Orthopedic Rheumatology Association, Patna. And he is also patron of Geriatric Orthopedic Society of India. I welcome Dr. Jha. And I'm immensely proud, sir. I'm associated with you, and you are going to chair this session. Now I'll ask Dr. Anand Kishore Paul to please begin his lecture, and we will all listen to what he has got to tell us. I welcome Dr. Paul. Please share the slides of Dr. Paul.
Good evening, everybody. So I'm feeling a little bit shivering in front of the legends like Dr. John Ebnezer and Professor Dr. S.S. Jha. Dr. John Ebnezer, who is the author of different textbook. They have started. We have learned orthopedics from him. And Dr. Jha is as it called. It is a Pitamaha. Is a Pitamaha, so
Yes.
orthopedic surgeon. So without wasting my time, so we're starting this talk. It's a cross talk. Basically, you have to know yourselves. This is the essence of the day. So basically, what is your wealth? In couple of minutes, so we'll discuss about the wealth of our life, which is the actual wealth, not it is the car, house, everything, but see the wealth. What is the wealth? It is the walking speed, height, waist, strength, get up from chair, the ability to get up from the chair, calf. Most of the cases, this part of the body is significantly neglected, but it is a significant treasure inside you. I will discuss. And the balance, it is very, very important. So these are the wealth we have to go into cherish in a couple of minutes. So how to know yourself? So these are the questions every person in the nation, in the Indian nations, they can ask themselves. Are your walking speed is reduced recently? Are you taking the help of your hands during getting up from the chair? Are you frequently tremble or feeling tendency to fall? Are your height is reducing as you are approaching above 50? Your life begins, new life, but your height is reducing. Are your grip strength is being reduced? Are you reluctant to use the staircase physically? Instead, you want to use the elevators. So these are the answer. If the answer is yes, beware. Why? You may have lost your muscle mass. What does it mean? That is the sarcopenia. So it's a term we want to learn, and there are several authors. So sarcopenia. So what? So what does it mean? What does it that result? That leads to fragility, fracture from trivial fall or even without trauma. These are common fractures that you know, the vertebrae, the distal radius, proximal humerus, and the neck femur, and the resultant comorbidities, and the result is significant. From as less as reduced height, as there is some vertebral compression, there's reduced height from restricted activities of daily living, from the distal radius fracture, restricted lifestyle from the proximal humerus, there is significant morbidity and also lust. This is the last part, is significant. That is the most mortality it can become from the neck femur. There is another bad news. One fracture brings the news of the another fracture within 1 to 10 years. That leads to significant handicap, financial loss of the individual, society, as also the nation. So that is we have to bother. So we want to learn sarcopenia. Now there are so both the good news and the bad news. Which one I have to give first? So I will start with the bad news. So muscle loss starts from the younger age. So that is a very, very bad news, as the peak muscle mass and the strength usually occur around the age of 25 years. The amount of muscle mass gradually decreases as we age. So as we additionally, as if 70 years of age, so there is approximately 50% loss of the muscle mass started per decade. So we're very much careful about it. As you know, life expectancy of the Indian is about around 67 to 70 years. So now there is increase of population. So rising concern about the muscle weakness is a powerful bomb. It is much more powerful than the atomic bomb. What is that? Is a population explosion, basically the geriatric population. So basically, India has the second highest elderly, that is more than 60 years population in the world, with 8.6% of the global share in 2011, that is expected to increase of 20% by the year of 2050. So by 2050, more than 1/5 of the population will be geriatric, and that may exceed the total number of population in the China. So it is a very, very shocking news. Now we have to check the good news. It may be acute sarcopenia or it may be chronic sarcopenia depending on the duration. Usually, if it is duration is 3 months, so it is a acute sarcopenia. So we have to, there's a early evidence that there is a need of the day to diagnose the sarcopenia as early as possible within 3 months. It is a good time. And if it is more than 6 months, it is a chronic that may not be reversible. So acute sarcopenia, if it is less than 3 months, it is diagnosed within 3 months, it is reversible. So what is sarcopenia? Basically, I want to draw the attention on this word, which is red. So it is a progressive and generalized skeletal muscle disorder. So as per European Working Group on the sarcopenia in the older people, so this word is progressive. Once it's detected, we'll be very careful because it is progressive. Now, this nomenclature, as John sir has rightly mentioned, the nomenclature has been changed. So initially it was only sarcopenia. It is only osteopenia, osteoporosis. Now the nomenclature has been changed. It is a sarcoosteopenia. It is a sarcoosteoporosis. Why it is important? Because both are correlated with each other. Both are they are related with each other, and they are very much, there's common factors of fall, fractures with attendant morbidity, reduced quality of life, and mortality, as I discussed. So muscle weakness, there is undertreated factor behind the poor outcome in orthopedic patients. So there is always crosstalk between the muscle and the bone. There are several references, as you can see here. So this is a very, very important notice. So there are several risk factors. I'm not going into detail. Vitamin D deficiency, metabolic dysfunction, corticosteroid use. There are several non-modifiable factors and non-modifiable factors, which is responsible between this effect. Now, basically what happens? Mechanical load that leads to some factors, which is known as these factors. There is the IGF, FGF factor, and irisin, and that leads to bones. Once it's got that signaling, they can use another factor. So both these factors are required for this bone health. So this is the myokine factor and the osteokine factor. They are both there. There's a bidirectional communication between this muscle and the bone, which maintains the muscle strength, bone mineral density, as well as overall musculoskeletal health. So this is a joint platform. Now, if there is a lack of the load, so what will happen? This lack of load, bone and muscle, they understand the language of loading. So there are between the crosstalk during the loading only. So if there is a lack of load, so what is the problem? Lack of load leads to weakness of the muscles, which can lead to disease or the aging. So there is a liberation of the myostatic factors, and then some inflammatory factors like interleukin-7 and the interleukin-6 that leads to reduction of the bone mineral density, bone mass, and the strength, leads to several problems as falls, fracture, fragility, everything. And that ultimately leads to reduction of the muscle mass, strength, and the function, leads to permanent muscle weakness. So these are the factors we have to understand. And that leads to permanent muscle weakness, leads to reduction of the muscle mass, strength, and the physical function. Now one can ask, what is the difference between this sarcopenia and these wasting or the atrophy of the muscles? In sarcopenia, there is reduction of these number of the muscles as also the size of the muscles. Whereas in the muscle atrophy, suppose in the disease atrophy, which is seen by temporary immobilization, there is a reduction of the size, not the number. So here there is a permanent loss of the number of the muscles, sarcopenia. So that is why it is so dreaded and it's dangerous. So relevance, what is the relevance of this muscle weakness in the orthopedic care? So there is a prevalence of the muscle weakness. There's a prolonged length of the hospital stay. There's higher rates of non-home discharge and increased mortality. And see, there are several diseases which is related with this. There is a significant loss of the muscle mass and the function. There is osteoarthritis, orthopedic surgery. See, this is 95%. 95% is which is the orthopedic surgeries, which is done in the geriatric age group. There is significant osteosarcopenia, it is noted. Apart from the spine disorder, rheumatoid arthritis, fracture, and the and so that leads to common factors, osteosarcopenia, which is overall 64.3%. See, these are the several diseases which is related with this osteosarcopenia. So now the question is it the only a musculoskeletal problem? No, sarcopenia is frequently underdiagnosed, inadequately managed, and undertreated. That leads to reduction of the quality of life, functional impairment. There is increased risk of disability, increased risk of fallen fractures, mental depression, and anxiety. So there is a multimodal disability of the effect of the osteosarcopenia. Now the question is how the muscle weakness starts and affect the human. See, up to 30 years in the early life, we can make the increase our savings, but there's increased production of the muscle mass. So in the first 30 years of life is very crucial. From 30 years to 40 years, so there is the reduction of the muscle mass. That is, we are using our savings. So our expenditure and the production is equal. So once we crosses the 40 years, so we are using our savings, our production will be less, our expenditure will be much more as we are real life. So we'll be very careful. We have to increase our savings up to 30 years of life. Now, molecular pathway. What is the molecular pathway of protein synthesis? I'm not going to detail. So this basically is the formation of these mTOR factors from this P1, P13K, AKT pathway, and that is the main pathway by which the muscle protein is synthesized, which increases the muscle growth. That can be increased up to 30 years of age, past 30 years of age. Now, it is a muscle synthesis is a dynamic process. As you can see here, so as we grow, so there is a reduction of the protein breakdown and increase of formulation, as I've stated, as the age grows. So that is leads to the maintain this equilibrium. That means a equilibrium up to 40 years of age. Now, what is happening after 40 years? There is increased protein breakdown, reduction of the protein synthesis. So there is a muscle reduction of the muscle formation. And ultimately, there is a number and size of the muscle fiber is reduced. There is a full-blown picture of this sarcopenia. Now, what are the pathways of muscle protein breakdown? So what are the different pathways? One is this protein breakdown pathway. As you can see, there are the UPS system, and that's the one is interesting, the FOXO gene. So this is the genetic pathway. So once you can easily notice some persons, they are maintain their physical ability, physique for a long time. So because of this genetic factor. But some they reduce their reduce their body physique very quickly because of this FOXO gene. So this is a genetic factor. If it is influenced, that we can maintain our muscle mass. So is there any way to externally we can whether we can change, we can influence these FOXO genes? Let us see in our next part of slides. So both this pathway is responsible for increase of protein breakdown and increase of muscle mass and the muscle weakness. Next is the inflammation. So inflamed muscle that can lead to liberation of the several inflammatory factors, as also the myostatin factors. This is the fibroblast proliferation and the fibrosis that leads to further damage, muscle atrophy, and the muscle weakness. And next important is the mitochondrial changes. So mitochondrial, if you know, this oxidative phosphorylation is going on, or oxidative pathway is going on this mitochondria. But the mitochondria sometimes they work differently and they produce this sort of reactive oxygen species, and that leads to damage. Instead of doing this increase of energy, they can cause damage to the body. And that can lead to several reduction of the several pathways, reduction of the ATP storage and the redox signaling. And they have these pathways that has to be suppressed by any way. Otherwise, that can damage the cell. Now the question is a burning question. Is it reversible or irreversible? Now, what are the ways by which it can be reversed? See, the weakness changes the structure of the muscle. It persists more than 6 months, I've already stated. So it is a chronic sarcopenia. It is very difficult to make it reverse. So there are several pathways I'm not going into detail. So that leads to permanent the reduction of the muscle mass and the function. So what are the changes? So chronic inflammation, that is to reduction of the blood flow and the amino acids to the muscles, reduction of the neuronal number and the acetylcholine release, increases lactic acid accumulation. That is why in the older age, patient may, most of the older persons, they feel body aching all over the body. So the back pain without any reason. So that is the reason of this back pain all over the body. Therefore, the early diagnosis and the treatment of this osteosarcopenia is the call of the day. Now, how to detect the victims of osteosarcopenia? This is the most important factors. Now, what are the risk factors? See, these are the different risk factors: nutritionals, inadequate protein and energy intake, deficiency of essential micronutrients, and several I'm not going to detail. Physical activities is a prolonged bed rest or sedentary lifestyle is very important, and low levels of the physical activity. Underlying medical conditions, there are several underlying medical conditions, and the iatrogenic factor is the hospitalization. Most of the older patients, those who require hospitalization, we need to mobilize as early as possible. Otherwise, that leads to this sort of problem I already highlighted before. And also there is a medication related muscle mass, muscle loss. So we have to understand. So I'm not, this is not the scope of this lecture. So I've just skipped it. Now, what are the tests by which we can muscle assessment can be done as a diagnostic cutoff. So there are some gait speed, the grip strength. There's a 5-chair stand test, and there is a cuff circumference. So everything we have to check and see. This is the gait speed. So we have to ask the patient to walk for at least for a 1 meter, and we have to check the how much the gait speed is there. So this is the normal gait speed. Grip strength, there are some dynamometer. You can use that dynamometer. We have to check the grip strength for the male and the female. So the chair stand test. So you have to ask the patient to stand from the sitting position from the chair for 5 times to check whether this they takes much more time, more than 12 seconds or not. Last one is the most important, is calf circumference, the part of the body which is most neglected. It is the calf, but it has a much more important information. I will highlight in the next slide. So this is strength, assistance to walking, rising from a chair, climbing stairs, and the falls. This is SARCF questionnaires. What is that? SARCF questionnaire is a self-assessment questionnaire. See, every word has some specific implication. S for strength. Which strength? It is a grip strength. It can be measured by the dynamometer, or even without dynamometer, one can easily understand that says grip strength is going to become reduced from the previous time. That is sufficient enough. And SA for assistance with walking, whether we need some assistance during walking. So I feel a little bit comfortable if I hold some railing during walking. So these are the assistance. This is the initiation of this assistance. Or for the rising from a chair, whether I want to take the help of the hand during rising from the chair, or that is most important. C for climbing stairs. So I am reluctant to use the climbing the stairs. I am using the elevator. And as a fall, we have a tendency to fall. So your score, so is from 0 to 2. So suppose strength is almost significant loss of strength 0. The significant loss of strength is 2. It is sound strength is 0. If the highest maximum score is 10, so if the sharp force is 4 and more, that warrants more testing. So who have to be screened up? So if the SARCF, it is more than 4, there is deteriorating. All people more than 60 years of age, all patients with chronic comorbidities, all patients with chronic inflammation, all patients with risk factors such as the prolonged immobility, critical illness, and the malnutrition. Now, this is a very interesting study. Now, the one bone of a vertebra that can tell much more news. Which vertebra it is least involved in our wedge compression fracture? That is the L3. You can see this dorsal lumbar region is the most common area. It is affected. L2 is the next, but the L3 vertebra, it is the least involved in our wedge compression or this or any fracture. And this is the study. There's a Morjakis et al. In 2008. They have found that this quantification of the L3 bone mass, the cross-sectional area, this is correlated significantly with the whole body muscle mass. So L3 bone mass that can reflect the whole body muscle mass. So that is an interesting study that is I will put it on. Another is the standing calf circumference. Standing cuff circumference is recognized by the Asian Working Group of the Sarcopenia in 2019 consensus, and the WHO as a marker of the muscle mass in the older adult individuals. I'll show what is the cutoff mark, and this is a study. There's a Kamiya et al. 2020, and the Kim et al. 2018, and the Lim 2020. So they have highlighted the cup circumference. If you measure your cup circumference, you can understand that there is a possibility of sarcopenia in yourself. Now, what is that tool? That is ISHI screening tool. So if your age is more than 60 years, your grip strength is going to be reduced, and your standing cup circumference, normally it should be 34 to 35 centimeters. Standing cup is in the middle of the cup. You can measure like this. So if it is less than 31 centimeter, so you become very beware. There's a high chance of osteosarcopenia. So we can take the measure. Now, another is the Frax tool. So Frax tool, that is a tool for detection of the fragility fracture. So there is some parameters to be filled it up. There is a age, sex, weight, height like this, and we have to make the BMD scan, DEXA scan, and DEXA scan. The score should be applied. This is an online score. So online, so everything. If you go to the internet, there's a new Frax Plus. So you can just put it your parameters, and you have to do the DEXA scan parameters in this way, and that is automatically it will come the risk factors of the fracture in the coming 10 years, 5 years and 10 years, hip fracture and the major osteoporotic fracture. So can easily be understand whether we have to take the care of or not. Now, another important factor is the sarcopenic obesity. One may call that I'm looking very hale and hearty. My weight is good. So I'm get rid of, I have no chance of risk of osteosarcopenia. But it is don't be very much confident enough. There's a waist to hip ratio. So the waist to hip ratio, if it is 0.9 is male, 0.8 for female. If it is exceeded 0.9, that is if 1 or more, that is directly related with cardiac disease and a type 2 diabetes mellitus. And there's also definitely osteosarcopenia. And there is some infiltration of the fat inside the muscles. So it is looking like very healthy and hearty, but it is unhealthy. And this is known as sarcopenic obesity. So he is very careful about it. Now, what are the management strategies? So preservation of the muscle health is possible by both the non-pharmacological and the pharmacological ways. So current therapy is a multimodal approach. So the pharmacological therapy, nutritional therapy, physical exercise, psychosocial therapy. There is no specific drug treatment till today. Now, what's the pharmacological therapy? The use of the drugs to treat the prevent sarcopenia is still too scarce. Now, the medications like testosterone, there's gonadotrophic hormones are being used, but there are several complications. However, they're associated with there's adverse reactions like cardiovascular risk, fluid retention, and the cancer induction. Now, the exercises. See, there are studies, there's association among the knee muscle strength, structural damage, pain, and the mobility in individuals in osteoarthritis. They have shown the specific exercises, especially the quadriceps and the hamstring muscle strength, is associated with less pain, less difficulty in completing the activities of the daily living, and the better mobility. So it requires some intervention. Another study, it shows this is a nutritional interventions combined with the muscle exercise, both. So that on sarcopenia patients on the femoral fracture, and that can lead to significant effect or prevention of the femoral neck fractures. What are those exercises? Specific weight-bearing exercises can prevent and treat the osteosarcopenia, reduce the fragility fracture. This is the this consensus, or this is study which is highlighted. Now, what are the exercises? Now, it is very difficult for the geriatric individuals to do all the exercises. One important finding is a Tai Chi exercise. It is like a freelance dancing, which it increases the flexibility, muscle strength, as also the balance. It's a Tai Chi exercise, very important. But these are the exercises every geriatric persons that can do. It is a hop squat exercise, hop squatting exercise with the help of some support. See, this exercise, this is a static exercise. Just try to make a half squat and then again make a erect posture at least for 5 to 10 times of the day in the morning. So that will help to make strengthen your back muscles, the three muscles, the gluteus maximus, quadriceps, as also this gastrosoleus, that maintain the cup circumference adequately. And so that is very, very important. Everybody can take. They can do that in the early morning at least for 5 to 10 times. Now, this is the tip to exercises, especially for this gastrosoleus. And along with that, we can help, everybody can take the help of the support. And so this is it's strengthening the quadriceps and also the gastrosoleus, and that can help also in the balance. Now I get somebody can tell, I'm very busy, I don't have any time to do this sort of exercises, is very cumbersome for me. Now I'm showing as another exercise, which is a very, very useful exercise. Even everybody can do during their workplace, even during the journey of the travel. So this is the sitting pushback exercises. This is actually it is under study, under my supervision. Now it's a very, very useful exercise. This is a 80 years old lady. He is doing. He's sitting against the wall on a stool. So he has presses the head on the wall. He presses both the elbows against the wall, and he presses the back against the wall. If she want, he can keep some pillow in between the back and the wall, and push both the lower limb on the floor. So at the same time, he can try to make contraction of the lower abdomen for increasing their urinary incontinence also, and also squeeze the anal muscles also. They are in an endeavor to prevent the defecation. So that has a pelvic support, pelvic strengthening, muscle strengthening exercises. The same thing, just make press against the wall and the floor. So count 1, 2, 3, 4 up to 20. So you don't require any restriction of the respiration. They can do by anything. So there are some limitations. Because the exercise takes time, requires self-discipline, it's very slow progress, and the patients can be easily demotivated. So sarcopenia is a challenging. There's a lack of awareness. There's no specific drug treatment, therapeutic nihilism, patient compliance, physical perception. Now the questions: if the muscle loss can be counteracted by the oral therapy, so there are some attempts. So I can suggest some medicine, some elements which can be used for everything. I want to experience of different faculties and panelists, and also from other doctors, respected doctors. So I can suggest this. So see, there is supplementation, muscle weakness. You can see there's some muscle non-specific and muscle specific, some see the proteins, vitamins you can take non-specifically, but some specific muscle specific substance is basically, it is the hydroxymethyl butyrate, carnosine, and the leucine. It's the branch chain amino acids. These are, if you use, this is by several studies, it says proved that this hydroxymethyl butyrate, as you can see here, hydroxymethyl butyrate, that acts on the damaged muscles. They can increase the mTOR. They activate these sarcomeres, increase the ATP biosynthesis, so enhances the muscle growth and the repair, and so this new muscle synthesis. They stimulate the muscle for production. Okay. Now the carnosine basically act on the damaged muscles. So basically they reduce the breakdown. So they can act on this phoxogen pathway. They reduce the lactic acid accumulation. They reduce the muscle protein breakdown. They reduce the pain and the fatigue, enhances the muscle growth, repair, and the new muscle synthesis. Okay. And this is astaxanthin. It is a natural occurring antioxidant. So as you can see, it reduces the redox potential of that is the ROS production of the mitochondria. So it increases the sarcomeres number, improves the autophagy, and this reduce the oxidative strength, enhances the muscle growth and the repair, new muscle synthesis. So it acts on the genetic level. So it acts astaxanthin. It acts directly on the phoxogen. It acts on the genetic level. It stimulates the synthesis of the muscle fiber. So these three, that if you use the combine on these, that significantly improves the muscle mass, strength, and the performance, endurance, recovery, mobility, reduces the muscle pain and fatigue. So what is the conclusion? Muscle weakness is related with the bone health, fall, fragility, fracture, directly related with the morbidity and mortality. It improves the muscle health and the strength is possible by the multimodal ways. A muscle-specific supplementation such as the hydroxymethylbutyrate, carnosine, and astaxanthin may be applied and is beneficial to improve the muscle mass, strength and the performance, endurance, recovery and the mobility, reduce the muscle pain and the fatigue, thus reduce the risk of the fall, fragility, fracture, and as a part of the multimodal treatment that can be useful for the treatment of osteosarcopenia. So I end here and I'm handing over to the panelist, respected John sir, and also to Dr. Jha sir.
Right. So, Dr. Pal, you have done great justice. You have done extensive workup on this problem of sarcopenia. I just have one question from you, that you have rightly said, if you diagnose them in acute stage, it is reversible. But if it becomes chronic, it is irreversible. But still, you have emphasized that with the workup and nutrition, things can improve. So, would you like to once again clarify?
Absolutely, sir. So that is the one thing I just clarify. It is the नामुमकिन तो नहीं होता है कभी.
Right.
Yes, I have
So
not
there is
used the
always
word
a hope.
irreversible.
Right.
I have word the reversibility becomes problematic if it is chronic. So nothing is impossible for a human. So once it is diagnosed, even if it is a chronic stage, so if you have to use the multimodal pathway, there is a hope to increase the muscle strength at least. So we cannot increase the muscle number.
Yes.
We cannot increase the muscle number, but we can increase the remaining whatever the number of muscle fiber is remains, we can increase the strength. That is, I think, it is my experience. What is the John sir? What is your experience, sir?
Well, first, congratulations on an excellent presentation. It was very lucid, and you gave a broad outlook of sarcopenia. I must confess then that, being an orthopedic surgeon, I was overlooking sarcopenia and only trying to treat osteoporosis. And we orthopedic surgeons are, known for not treating both osteoporosis and sarcopenia. We are only interested in replacing the joints, fixing the fracture, and sending them home. And my own mother-in-law, at 83 years, she had a hip fracture. And then within 3 months, she had another hip fracture and she passed away because of that. And I never gave even one simple treatment for her for osteoporosis. So I am guilty. But subsequently, I improved and I started putting the patient on treatment for osteoporosis. But sarcopenia, yes, this whole thing was overlooked by me. I think most of we orthopedic surgeons are guilty of this. It is not only me, plenty of people. We don't know how to diagnose sarcopenia. And now that you are given very clear-cut diagnostic tools and simple tools like hand grip, getting up from the chair 5 times, calf muscle, so easy to understand. So this simple test, which you have shown is going to be very useful to me now. I can do this even in my outpatient clinic and diagnose whether this senior citizen is having sarcopenia. And there is one confusion for me. I would like to ask you, Dr. Anand, that the BMD test, what we do, is for the Z score, what we do, or the for the osteoporosis, osteopenia. Now, how is that going to help us diagnose the T score? How is that going to help us diagnose sarcopenia? That I'm not very clear about that. So I wanted to know from you whether the BMD test is useful to detect both sarcopenia and osteoporosis.
Yes, a very good question, sir. So basically, there with BMD score, so there is a 2 score. There is one in T score, and another is a Z score. T
Yes.
score is basically, suppose it is a 50 years old person. That 50 years old person's bone mineral density is compared with a 30 years old same sex, that is male or female. So if it is a standard deviation minus 2.5 standard deviation below, it is known as that is osteoporosis previously. And is a Z score is basically it is the 50 years old male. It is compared with the BMD score of a similar 50 years old male person with all similar character.
Okay.
That is why obtaining a Z score is very difficult, because the finding of a similar type of patient of a same age, sex, of same character, same comorbidity, so it is very difficult. So most of the cases T score is used. Now the
Okay.
question is, T score is basically it is used for detecting the osteoporosis.
Correct.
Okay. Now the terminology has been changed. It is a osteosarcopenia or osteosarcoporosis, sarcoosteoporosis. So in most of the cases, the osteoporosis it is correlated, it is associated with osteosarcopenia or osteoporosis. Sarcopenias are correlated with each other. So if the patient is diagnosed as osteopenia or osteoporosis, the patient must have sarcopenia.
Okay.
So
there
that
is
is
no
how.
there is no specific criteria in BMD which tells about sarcopenia.
Absolutely, absolutely.
If
Yes,
a
there is a
patient,
DEXA scan, and
Mhm.
there's a bioimpedance analysis test, BIA, bioimpedance analysis test, and the DEXA scan study, by which we
Okay,
can
both
see.
the T score and Z score.
Now that is the
Both the T score and
different
the Z
calculation.
score. Yes, yes. Now both the T score and the Z score is related to osteoporosis or osteopenia.
Indirectly, we can diagnose that there is associated sarcopenia.
Okay. So indirectly we can diagnose. There is no specific reading in
Specific
the
only
BMD.
two ways, sir. There is a specific DEXA scan. That is a different way of calculation of this bone mineral density. There's a muscle calculation, and another is the bioimpedance analysis test. So that is two
Bioimpedance.
tests.
Okay.
Yes. This is critical
Okay.
test. It is not out within the control of the general population. So it is a simple way to make the BMD, because, and you have to, most of the cases, we have to understand if it's osteopenia or osteoporosis. There's most of the cases is associated with sarcopenia. That is the indirect evidence.
So Dr. Jha wants to add something.
Yes,
No,
sir.
I just wanted to say he is right, and he has said there is a correlation between lumbar third vertebra, BMD, and sarcopenia. But he has also said there are now modification in modern DEXA machines where you can do muscle assessment. They are peripheral assessment of muscles.
Absolutely.
So they are also available.
Is there any specific indication or marker or guide for us to when to start drug therapy in sarcopenia?
I don't think, sir. I don't think it's no specific drug markers which is reliable on that.
Or any criteria you got now this patient needs, other than non-pharmacological method, he
Yes.
needs pharmacological intervention also. Is there any the score what you showed, the SARC
Right.
score, anything like that, or we just start the treatment when
Yes,
we
there is a guidelines of this European working group of sarcopenia. So you
Okay.
can go through this. It is available in the internet. So they have started the screening test which I have given, the SARCF code.
yeah, so based on that we need
Yes.
to start.
Yes, that could be a good guideline. But then I would like to say, since it is always associated with osteoporosis or osteopenia, so you see, if the male patient is of 50 years or more with morbidities like he is used to taking alcohol, current smoker, there has been a fracture of the first relation. So these patients might require treatment for evaluation for osteoporosis, treatment for osteoporosis, and simultaneous treatment for sarcopenia as well.
Okay.
Well, now, Dr. John, now I feel a great justice has already been done on the topic. So we can start interacting. Shall we proceed?
Yes, definitely.
All right.
There has been, I think, Dr. Upin, my teacher, is trying to ask a question. I guess he has been raising hands. Can he be put through?
Oh, yes. But all these questions could have been placed in the end.
In the chat box, they can be. Now, most of the questions I think is answered already by Dr. Anand Kishore.
Right.
One question I want to ask him. Where does this HMB, it is beta hydroxy, beta methyl butyrate, fit for sarcopenia, osteosarcopenia, especially around orthopedic care?
Yes, there are some medications. It is available in the market now. So I think you can go through the market, and there are some commercially available drugs where this hydroxymethyl butyrate is available. So you can use this with this therapeutic dose. So there's one capsule BD. It is available in the market. So anybody can go through this. So this is not this is beyond the scope of this lecture. So I am just suggested. So always you have to be proved by the experience of you also. So you can use these in your patient, and also you have to judge whether it is useful or not. But it is there are several. I have shown that some reported reports. It works well. So at least 3 months of using, you have to use 3 months along it's as a part of the multimodal treatment. I'm very regularly repeating. So it is at a part of the multimodal treatment. If you use this drug, this in combination, astaxanthin, hydroxymethyl butyrate, and the carnosine. Okay, so that can definitely increase your muscle mass.
And I wanted to ask, what is the role of anabolic steroids, and how we should advise the patients along with these oral
Personally, I'm
medications?
not using the anabolic steroids, sir.
You're not using. Okay. So I know Dr. Jha.
Anabolic steroids even do not have any place in osteoporosis, and definitely here also.
There is no place of anabolic steroids.
It just gives patient a fillip, and so it can be temporarily used, but there are no studies on that line.
Okay.
What I would like to emphasize that there is a testosterone, like you say, estrogen replacement therapy. So there is testosterone replacement therapy. But as he has rightly said, you have to take precautions. First of all, you have to evaluate your patient that he does not have any prostatic carcinoma, he does not have benign hypertrophy of prostate, and there are no such other problems. If it is not there, then testosterone in the dose of 200 to 250 milligram every 3 to 4 weeks can be given. It restores osteoporosis back also. It can improve osteoporosis, also sarcopenia.
Very interesting, sir. Testosterone replacement therapy.
Right.
Right. So TRT.
Right.
So we need to know more about this, because most of the senior citizens will definitely have prostate problems like BPH, all those things. So if that is a contraindication, then the scope of TRT drastically drops. Only very few senior citizens may not be having BPH, and maybe it is useful in those patients.
That precaution will have to be taken.
Okay. And then the next question is, Dr. Anand, do sarcopenia, osteosarcopenia independently predict arthroplasty or fracture care complications? Does it actually modify?
Yes, yes. It is a very, very good questions. Not only the arthroplasty, but also the geriatric patients who usually involved in fractures. They have been treated. They have to treated by a bed rest for initial period. Definitely, this sarcopenia that is affects how it affects. At least there are study. At least 3 days of bed rest that leads to significant sarcopenia, and that is why the bed rest is very, very harmful for more than 3 days in case of elderly. So that it help in reduction of these muscle function. There is a rehabilitation problem, and also for these if there is a rehabilitation problem, then there is a very difficult to mobilize. So there is a recovery will be delayed, and there is a high chance of complications.
And there is one more question which I want to ask. This pharmacological treatment of sarcopenia for sarcopenia due to surgery, post-surgery, sarcopenia post-fracture, and sarcopenia in geriatrics. You said that, we need to treat them for 3 months
Yep.
after the surgery is done. But what about the geriatric patients? Because geriatric patients, they are, going to, you can't just give them treatment for 1 month, 2 months, or 3 months and then say, come on, the dose is complete. No. So what is your take on this? Does geriatric patients need a long-term pharmacological therapies?
Yes, they can take, sir. That is why I'm already stated. You are the best judge, sir. So they have at least 3 months therapy. Why it is 3 months? Because I've already told the time limit of the acute sarcopenia and the chronic sarcopenia. So once you have diagnosed acute sarcopenia, that is within 3 months. So if it crosses the 3 months and still it persists, that means it is not working. Drug is not working. So you have to do something else. So that is why the cutoff limit is the 3 months.
Okay.
So
Right,
that is
Dr. John, I would like to say something.
Yeah, please, sir, please.
If you are giving supplement, and what they are protein supplements, and they are one of the essential amino acid, leucine, that is contained in calcium HMB. So if they use it for prolonged period of time, there are chances that you might they might be responsible for further production of osteoporosis, number one. Number two, they can produce kidney damage. So keep on evaluating your patient. That is osteoporosis increasing? Is kidney function working all right? And so that is that kind of 6 weeks break.
Okay. Now let us take some questions from the audience. There are some 9 questions which has come up. The first question is, can there be sarcopenia without osteoporosis and vice versa?
I will like to say that it is almost like a mother and a child in the lap, just born mother.
Okay.
Mother can speak, the newly born child will not speak, but whenever the child is hungry, it will cry.
Okay.
So that crosstalk between the mother and child is always important. We cannot isolate the muscle from the bone.
Okay.
So
Okay.
they will
Got it.
definitely
Got it. Got it. The next question is from Ishita Ladda. She is asking, if a patient has osteoporosis, we should give bisphosphonates and carnitine both.
Bisphosphonate and
Carnitine.
carnitine. Yes, yes.
We have to give. Great.
I will like to say you cannot generalize treatment of osteoporosis that bisphosphonate only has to be given.
Yes. So we have to personalize.
Yes, personalize. I always say that there are 2 kinds of osteoporosis: high turnover osteoporosis, low turnover osteoporosis. And number 2, you must also see that the serum ionic calcium, I'm saying ionic, not calcium. Ionic calcium is more or less. Hypercalcemia, don't use teriparatide. Hypocalcemia, yes, bisphosphonate is the drug of choice, or denosumab. But if there is pregnancy or the mother is there is lactation, then again you don't have to give denosumab.
Okay. Now the next question is by Dr. Hemant Praveen. He is asking, what is the pharmacological treatment for sarcopenia? I think Dr. Paul has covered it. You can just briefly just say, sir, the pharmacological treatment. You can just briefly again recapitulate back for those who have not completely grasped it.
I will like to say that calcium HMB is naturally produced metabolite of essential amino acid, which is leucine in humans, right?
Okay.
So this has definitely emerged as a promising agent for muscular health. What it does, it increases something and it reduces something. It increases muscle mass, strength, muscle growth, and muscle quality. Also improves lean body mass, functionality, and endurance. What it reduces? it reduces muscle loss in disuse and muscle damage and muscle soreness, and also reduces fatigue.
What
It's
is that? What is that drug, sir?
calcium HMB.
Calcium HMB. So that's the
Yes.
message.
Yes.
And to Dr. Hemant Praveen.
All right.
Then a question by Dr. Suresh Shinoy, which we have already discussed this role of anabolic steroid. They have categorically said that, anabolic steroid, Dr. Paul is not using, and Dr. Jha has very
No
clearly
such
said that.
studies.
Yeah.
We are not to be biased. There are no such studies which has proved that it has a positive role.
Okay. The next is role of vitamin D injection and the period of calcium. Role of vitamin D injection and calcium.
Either you are treating osteopenia, osteoporosis, or sarcopenia, vitamin D and calcium have their definite role. And
Okay.
the turnover has to be decided by investigating ionic calcium and bone-related alkaline phosphatase, so BAP. So these two things will tell us what is the status of bone turnover.
Okay. Then Dr. Rajendra Upin, professor, my teacher from JNMC Belgaum. I'm happy he has joined the seminar, and he's always very, very sportive and very, very, friendly in his approach to all his students. He is asking a question. Drugs dose therapy in sarcopenia. What is the dose for the drugs we use in sarcopenia?
It is calcium HMB plus L-carnosine plus hexagenthine. So calcium HMB has to be 3 gram per day. This capsule that is being given has 75 gram in one capsule. So ideally it should be, you multiply how many capsules it will be. So 3 gram per day.
3 grams per day.
Yeah.
Thank you, sir. Then one question by Dr. Sanjeev Divyadarshi. How is sarcopenia or sarcoporosis diagnosed? I think Dr. Paul has made it very clear. The tests, the screening test, what he told, and the hand grip, and whether person can get up without from the chair without using the armrest, the calf muscle, and the height, and the gait. So he has told how to screen for sarcopenia, and I think he has elaborately discussed that. So anything else to add, Dr. Anand Kishore?
And Dr. John, I will like to say one thing.
Yeah.
While talking about exercises, there are certain recommendations that you should walk backwards.
Yes.
Luckily for me, I have received so many compression fractures of the vertebra while the patient were walking backwards. So I will say,
you should publish it, sir.
Especially in geriatric case, number one. And number two, half squats. If you are holding a light chair and making half squat, maybe you might fall. So let somebody sit on the chair, and then the other person does the half squats.
Yes, sir. I think what you are telling is absolutely right, because geriatric patients, may fall because the lack of balance and other things. These squats may be, quite stressful for them on the knees also. I fully agree. I was always getting tempted while listening to this backward walking. Whether I should do this. Maybe these Japanese people popularize this. Now you have told that we fall, so better avoid it altogether. And there's very interesting question which has come up here. Dr. Raghunandan Bisoy asks, I don't know what Dr. Anand Kishore Paul is going to tell about this. Can sarcopenia be seen in pediatric age group?
Oh, no. So basically, it's a sarcopenia. It is the reduction of the muscle mass as also the function.
So it is not seen in pediatric.
No, it's not.
Even in chronic disorders like nephrotic syndromes or rickets, something like that.
I will just like to add, previously, let's talk about osteopenia, osteoporosis. It was an adult phenomena. But now pediatric osteoporosis has come to stay as a different subject altogether, So if we can, like patient of osteogenesis imperfecta, so there are pathologies galore in pediatric age group where there could be osteoporosis as well as sarcopenia. Now, would you agree, Dr. Pal? Yeah. Okay, you can go ahead, John.
Yeah, so osteogenesis imperfecta, Dr. Anand Kishore, what Dr. Jha is asking is, in osteogenesis imperfecta, there could be sarcopenia. Do you agree?
There is some problem with Dr. Pal, but
Okay,
we have
then
done extensive work on osteoporosis, so I am aware pediatric osteoporosis exists, and so sarcopenia can be an accompaniment.
All right. And one question from Dr. Sanjeev Darshini, the other, are the tests for osteoporosis, will they give the idea on sarcopenia? That question has been answered. If there is low BMD, it indirectly tells that the patient has got sarcopenia and you go ahead with treatment. Then there is some more questions which has come up, like what is the status of muscle contractures regarding sarcopenia? And in that connection, can stretching exercise help sarcopenia? Yes, I think stretching exercise, resistance exercise can definitely help sarcopenia. In this context, I would like to tell mind-body exercise like yoga and Tai Chi will definitely help in stretching and improving the balance, coordination, gait, and the finger and the muscle strength all over the body. I think this definitely help. The stretching exercise and the mind-body exercise will help in the management of osteosarcopenia. Then there's a question from Neha Agarwal. Again, the same question. Is sarcopenia possible in young individuals who have started gym?
Started gym. So if the patient has been onto the gym exercises, so you are building up your muscles as well.
Yes.
And
there is no question.
Through the muscles, you are loading the bones. So there is anabolic activity. Right.
I don't know, sir. Maybe today's, nowadays in gym, they might be, what to say, showing them how to lose muscle mass also. Otherwise, how do you, think that patient who goes to gym will lose the muscle mass?
Wants to say something.
Yeah, tell me, Dr. Pal.
Is just joining the gym doesn't mean anything.
Yes.
So you have to increase the muscle mass, muscle endurance, flexibility.
Correct.
And the endurance that is by with the help of this.
Basic question was,
yes,
Dr. Pal, the basic question, if you join gym, you may have sarcopenia.
Yeah. Is it possible?
No.
Okay, I don't.
So it is totally opposite. Opposite question.
At this stage, I would like to make one statement that if your patient is obese and elderly, would you advise them to lose weight? And the answer is that do not advise them to drastically lose weight, because sarcopenia might increase.
Absolutely.
Yes.
Absolutely.
Yes, the rule of thumb is around 2 kgs per month. That would be the ideal thing. Not doing over exercise and taking a lot of weight loss drugs. It is always better to go slow. 0.5 kg per week. 0.5 kg per week. 2 kgs per month would be reasonable, and the body will adapt slowly. And then I think the last question here is, for patient of malabsorption syndrome, what is the treatment for sarcopenia?
No, malabsorption syndrome will be a contributory factor to sarcopenia. So you have to set right the GI problem. Maybe you have to give them some prebiotic, probiotic, and that will also naturally take care of sarcopenia, apart from the drug that we are advocating here.
Absolutely. This is agreed.
Yes, those were the questions. I think nearly 22 questions were posed. It shows that the audience interacted well with, they have found this lecture very useful. And we had more than 100 delegates participating in this program. Really and the interaction shows that, yes, that's very good. And before we wind off, and one last question to Dr. Paul. Yes. Is there a clinical support for antioxidant mitochondrial adjuncts, example, astaxanthin, in older adults during rehab. Is there clinical support
Yes, there
for
is a
antioxidant mitochondrial adjunct?
yes, there is one study which is not in human but is on a rat. So
Okay.
that it is extremely useful for improving the cell function by
Okay.
using this astaxanthin, and
Okay.
this is natural occurring antioxidants. So
Okay.
this is very useful for increasing this muscle mass in those cases.
Okay. I think we had a great session.
Just a minute, John. I would like just to make people conversant with one term, targeted prehabilitation.
Absolutely.
So
Okay.
once the patient comes with a fracture to an orthopedic surgeon,
Okay.
our aim should be that the rehabilitation post-operate, and we are going to operate on those patients. So a prehabilitation should be started before surgery so that patients start working as early as possible. And this will have to be various exercises through building up various muscles. So this surgical pre-rehabilitation is important. And one thing more, what is the responsibility of orthopedic surgeon? You have to see that at the time of discharging the patient, you must treat the osteoporosis so that the secondary fractures that are likely to come are prevented.
Thank you, sir. Thank you for your wisdom, advice, knowledge to young orthopedic surgeons that not only young, to all, that they have to treat osteoporosis, sarcopenia, osteoporosis, all. It should be a comprehensive holistic therapies and not just fixing the fracture and sending the patient home.
Right.
Yeah, thank you. Thank you, our panelists. Thank you, Dr. Anand Kishore Paul. It was an enlightening lecture. And thank you, Dr. Jha. As usual, you're full of wisdom, knowledge, and you alone could handle so many questions. And I'm extremely grateful to you. And I also thank the Pharmed company for coming forward to organize this extremely useful program. I thank thank my friend Jagan for taking so much of interest in this. And if there is any closing remarks by the Pharmed group, most welcome. You're most welcome to do so.
Good evening, everybody. I am Dr. Jayanta. I am
Okay.
Head Medical Affairs Pharmed Limited. I thank you, the panelists, Dr. John Ebenezer, Dr. Anand Kishore Paul, and Professor Dr. Shiv Shankar Jha. Thank you very much for joining and making this program meaningful. And I would also like to say that on behalf of Pharmed, we are very grateful that you have given us opportunity to join this program, organize this program, and we look forward to many more such programs in the future.
Thank you. If you can
Thank you
share
very
us
much.
if you can share us the recorded version and give us a link, we can send it to
Yeah.
a lot of people who could not attend the program.
Certainly.
Yeah.
And
thank you. Thank you so
the
much.
gratitude goes to this product, Improsin. Thank you very much, and we look forward to your supports. Thank you.
Thank you.
Right.
Thank you so much.
All the best.
Good night. Good night, everyone. Thank you.